Good evening, everyone. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioral and Neuroscience.
Recording in progress.
Banai is a not for profit organization formed in 2012 and has organized more than 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E.Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Anukan Mittal as the moderator for today's webinar. Thank you, Dr. Anukan Mittal, for accepting to be the moderator for the webinar. Dr. Anukan Mittal is a professor and head, Department of Psychiatry, Rajiv Gandhi Medical College, Kalwa, Thane. He is also the president, Indian Association of Private Psychiatry. Dr. Anukan Mittal is also the UNESCO Professor of Bioethics and Head Western Region, UNESCO Asia Pacific Chair of Bioethics. I would now request Dr. Anukan Mittal to take over and start the session proceedings. Over to you, Dr. Anukan Mittal.
Right. I hope I'm today. Welcome everybody. We have got very contemporary topics today. One is you are probably exhausted about attending and listening to long discourses about various aspects of COVID, neuropsychiatric aspects. Today, we are actually going to talk about the neurobiology of a long COVID. As you know now, the second wave seems to be subsiding, and we are, although anticipating the third wave, we are in a stage where we are looking at 1 year's data of people who had developed COVID in the past 1 year and currently are showing certain definitive morbidities which can be associated or can be attributed to the COVID illness or the treatments given during COVID. To distinguish that, we have a very eminent speaker who will help us understand the neurobiology of long COVID, and that is Dr. E.Mohandas, who is the chairman of the Behavior and Neurosciences Academy of India. He's a psychologist. He's a chief psychiatrist in psychological medicine working at the Sun Medical Center. He's one of the rare neuropsychiatrists who have won the World Federation Award for Excellence in Mentorship. He is also award receiver of the D.L.N. Murthy Rao, the Asian Federation International Award for Excellence in South Asia, the Indo-Australian Award for Psychiatric Training in South Asia, and he's the first Indian to be the chair of the WPA section for developing countries. And he is the chair of the International Institute of Organizational Psychological Medicine, the Indian chapter. He is an eminent author of many articles, books, chapters, and of course, he is the famous teacher of neurobiology and pure neurology of psychiatry to all of us. Then we have a topic. Can we go back to the previous topic? Yeah. Where we are going to have Dr. Rajesh Nagpal, who is an eminent psychiatrist from the Manobal Clinic in New Delhi. He is a partner in the Sarvam Neuropsychiatric Clinic in Kalka and in Jaipur. Kalka not in Delhi, but Kalka in Himachal. He's a trustee of the Deva Foundation. He's a chairman or section on developing countries World Psychiatric Association. He's one of the directors of the Behavior and Neurosciences Academy of India, and he's a director and professor, International Institute of International Organization Psychological Medicine. He is a steering committee member of the North Indian Bioethics Unit of Asia Pacific UNESCO Chair, and he's a Secretary General of Indo-Global Psychiatric Initiative. And he was the past president of the IAPP and IABP in the past years, and is actively involved in the teaching of psychiatric topics and picking up controversies in psychiatry. And today he is going to talk about the treatment-resistant schizophrenia and the role of Clozapine. So, without further ado, I wish to give you the good news that today we have two 5,000 rupee Amazon vouchers to give away. One is for the best question. You are requested to post your question answers. You can start by posting your questions even now. And the best comment. By best comment, we actually mean a kind of a constructive criticism or a constructive comment which adds value to the presentation given by the speaker or gives another viewpoint in a constructive manner. Uh, and that will be judged by us. So the winners would get 5,000 rupee Amazon vouchers, e-vouchers sent to them. That would be at the end of the program. So we will start with Dr. Mohandas, and then we would have Dr. Rajesh Nagpal, followed by the question answer sessions. Thank you very much, sir. Dr. Mohandas, can I request you to please begin?
Let me share the screen.
Yes, sir.
You can see the slides?
Yes, Mohan. Yes, Dr. Mohandas.
Yeah.
You can see them. Yeah, you can start here.
Yeah. My dear friend, the moderator and one Mittal, and the co-speaker, Dr. Rajesh Nagpal, both are eminent psychiatrists of India. And I was given the topic on neurobiology of long COVID. I was really stuck. What is short COVID and what is long COVID? Acute COVID, yes, but multiple waves. Where will you draw the line of acute and long COVID? Anyway, the neurobiology doesn't differ much, but I will try to explain what happens in long COVID also. The outline of the presentation will be basic facts about COVID-19 virus, COVID-19 entry to the nervous system, neurological manifestations, and mechanism underlying neurological symptoms. I won't be covering psychiatric aspects. As you pretty well know, the COVID timeline, the outbreak in China, December 2019, January 2020, outbreak in US, 30th January, lockdown in Wuhan, China, 30th January 2020, outbreak in India, especially in the first case was from my own hometown, a doctor. Outbreak in Italy on 31st January 2020, and pandemic declared by WHO in 2020 March 11th. Lockdown in India 25th March 2020. 1st June 2020 partial unlock in India. Again the present, not only waves, my second wave or multiple waves or whatnot. I think we'll go back to a little bit of history. People really have got two theories. Is it the COVID-19 has jumped naturally from a wildlife to the people, or is it an escape from the lab? If you go to the history, Dr. Shin Sheng Li, or the Bat Lady, he was doing so much research, molecular biological research on coronavirus, as requested by Peter Daszak, president of the Eco Health Alliance in US. But this lady had training on molecular biology under Ralph S. Barry, also in famous microbiologist from USA. But later, this is the Wuhan Institute of Virology. Now, Richard Bright, a famous molecular biologist of Rutgers University, has commended. It is clear that the Wuhan Institute of Virology was systematically constructing novel chimeric coronavirus and was assessing their ability to infect human cells and human angiotensin converting enzyme to expressing mice. is famous, and now there's a doubt, is it a bioweapon? 3 days back in the news, it has come around 40 viruses are there which might be used as bioweapon. We do not know the veracity. Even our neighboring country also is involved in the mutual arrangements. We do not know. Now the statistics, this is 2 days back. It is rising statistics. I call it waves. The coordinator has told, Anuganda has told it second, but I put it multiple and questionable. We do not know when second, third, fourth, fifth, we do not know. Exactly, we do not know. But confirmed cases are plenty, as you know the statistics. This is, as you pretty well know, it is 2.5 crore plus, and the deaths are also getting increased, especially in the second wave. In Kerala, as on 22nd May 2021, confirmed cases high, but mortality is supposed to be less, deaths are less, but it's a fact or fiction, we do not know. But now it is rising, but vaccination has been done already in almost 19%. All over India also around 20% plus. What is the COVID-19 virus? It belongs to the coronavirus. Coronavirus family is a single-stranded RNA virus in the order Nidovirales. This is SARS-CoV and SARS-CoV-2, COVID-19. Primarily infect mammals and others primarily infect birds. These are birds. So this is a single-stranded RNA virus. The coronavirus particle has got mainly four structural components: the spike glycoprotein, the spike protein, the membrane protein, the envelope protein, glycoproteins, and nucleocaspids. That is plus single-stranded RNA positivity. Now, as I have already told, spike protein has got two components. One is S1 and S2. Yes, the spike consists of homotrimers of S proteins responsible for mediating COVID entry to the host cell. It has got two parts. This is S1, this is 2. That means there is a bulb responsible for receptor binding, and there is a stalk that contains the fusion machinery. This I got from the recent article from Biochemical and Biophysical Research Communication, recently written by Santopolo from Italy. Now, SARS-CoV-2 virus, there's a precursor. This is called SP, but there are two portions which I have already told you. The S1, there is a N-terminal domain and receptor binding domain. These are the binding. But in S2, we have got a fusion peptide. We have got a heptapeptide repeat 1 and 2, and transmembrane anchor domain, and also the C-terminal. So this is the N-terminal domain, receptor binding domain. This is the subdomain 1 and subdomain 2. Here is the S1, S2 cleavage happens. The protease cleavage thing. Here is the fusion peptide which belongs to S2, and you have got the heptad repeat 1 and heptad repeat 2, and you have got the transmembrane domain and cytoplasmic tail. S-class, the surface protein is a S-class 1 fusion protein with helical heptad repeats. The first cleavage site is at S1, S2. The second cleavage, that is S2, libates internal fusion peptide within the S2 domain. Now, the RNA genome of SARS-CoV-2 virus has 29,811 nucleotides encoding for 29 proteins, though one may not get expressed. So already described, this is the spike S1, and here is the transmembrane proteases, that is serine 2, or even furin for priming, S protein priming, and then it gets binded to the AC2. S2 is here after the cleaving, it goes to S2. That produces the problem. Now, as I've already structural proteins, these are 4, which I've already told. But there are so many non-structural proteins called open reading frames, ORF 1A, 1B, and multiples. Now, coronavirus, single-stranded RNA virus, I have already told you. The largest portion of the genome at this end, that is N-terminal N, encodes ORF, that is open reading frame A, B, A and B, and these are non-structural proteins involved in replication of the virus. Smaller part of this encodes the structure. Basically, the glycosylation is a complex process which I will not discuss today because I have got a limited time. 6 accessory protons are encoded by open reading frame 3A, 6, 7A, 7B, and 8 gene 3, that is the N-terminal and 3 end of the genome. It is highly complicated, so I will just put it in simple. N-terminal surface subunit S1, it produces receptor binding. The C-terminal, that is the last one, is S2 of the part of S2, mediates viral internalization. Upon binding to its receptor, S protein is cleaved by specific proteases. I have already told you that release is got, initiating membrane fusion and virus internalization. The cleavage is mediated by transmembrane serine protease 2, also by furin. Some cases will be primed. Several other receptors have been identified that serve as potential receptors for COVID infection, like neurophilin 1, CD147, furin, catherine, etc. Now, we do have, now people talk about many mutants. What is mutants? Each new copy of a virus contains a tiny copying errors or variation in its genome. That is why it's called variant. Variants are highly transmissible, may be more virulent depending upon the case. For example, the initially reported from South Africa, the B1.1.7 and 135, and P.1 initially from Brazil and Japan. These are mutants. In India, initially from Maharashtra, that is Anugan's region, double mutation, E484Q and L452R mutation have been described, but it is similar to E484K is mutation seen in South African variant and also Brazil variants. So there are some overlaps. But here, the second mutation, that is the L452R mutation, is this one, the double mutant. It really corresponds to a lineage in US which is sometimes called the California variant or Ken variant. But California variant. In UK variant or Ken variant and Visakhapatnam or Kurnool variant M46A, which might be really affecting the South Indians, etc. Recently, the so-called Indian variant, we are not supposed to talk about Indian variant, B1.617, it is now put by WHO as a triple mutant, not dual mutant. There is variant 618 also. Now we'll go to the viral cycle quickly. Binding of the S protein unit facilitates membrane fusion with the cell membrane or even by endocytosis, two mechanism. The viral genome RNA is lead to the cytoplasm. Audible? Anugant? Anugant? Am I audible? Hello?
Sir, partly. Sometimes it is going off air, sir.
But I don't know because my connection is like this. It is raining outside.
Fine, fine, fine. Carry on. We have a cyclone happening.
Yeah. The first open reading frame, ORF, is translated to polyproteins like PP1A and PP1AP. It is tough to understand. Now, these are cleaved by viral proteases like papain-like proteosis, that's PL-PRO, 3-chymotrypsin trypsin-like proteases, non-structural proteins such as RNA-dependent RNA polymerase, RDRP, that really application of the virus. Also, the budding of the virus happens at the endoplasmic reticulum and goes intermediate compartment. And structural proteins form new viral particles, then they are released by exocytosis. So summarizing, initially proteases activates proteinase by cleavage, union of S1 to angiotensin converting to enzyme, binding and viral entry by fusion and endocytosis, release of viral genome, then RNA genome and replication and translation, furin-activated cleavage at endoplasmic reticulum, Golgi complex, and structural surface, membrane, and envelope proteins unite nucleocapsid. That produces mature virions, then exocytosis. Recently, in Current Opinion Virology 2021, they are told that initially there's a receptor binding, then a protein cleavage, then the ions enabling membrane fusion. The trypsin-like and type 2 serine proteases cleavage at the cell surface, but two distinct subdomains, FP1, FP2, these are calcium binding sites, and endosomal acidification is by vacuolar type ATPase. I know that it is very tough to understand, but basics we have to know. Now, immunopathology, I will go faster. What happens in COVID? There is a lymphopenia, T cell activation, lymphocyte dysfunction, abnormalities of granulocytes and monocytes, increased production of cytokines, increased antibodies. Now, in COVID, depletion, the exhaustion of lymphocytes, lymphopenia, increase of neutrophils, and you can have a cytokine storm and antibody-dependent enhancement. This you can go through the journal signal transduction and targeted therapy. I don't know whether you can access, but I do have the article. Now we'll come to the topic in COVID-19 ND to nervous system. So if you see this, the neural axis involves transporting the virus to the nasal cavity through the olfactory route, olfactory nerve, and the rhinopharynx, through the olfactory and trigeminal nerve and lower respiratory tract through the vagus nerve, neural pathway. So there are three ways: orally via the gustatory and trigeminal nerves, apart from the olfactory route. Also, you can get spinally via the dorsal root ganglia. It can be from receptors in the skin or in the gut, or through enteric nervous system. The gut microbia axis you have heard, that is ENS. That is called axonal retrograde transport from infected peripheral neurons. Many people with COVID complaints of diarrhea initially. Olfactory route, viremic dissemination to the olfactory bulb. This olfactory bulb, that route, it produces dissemination to the brain, to the amygdala and piriform cortex. These are the main primary olfactory cortex through the medial forebrain bundle that projects caudally to the dorsal vagus nucleus and solitary tract, and also transsynaptic extension through the cribriform plate. It though it is olfactory route, there can be an invasion of the medulla. This might contribute to the respiratory failure in critically ill COVID-19 patients. I will come to the dyspnea part later. You can have a hematogenous route. Even the blood-brain barrier is intact, you can get it via the choroid plexus or circumventricular organ. Viral particles may pass through the fenestrated capillaries of circumventricular organs without a blood-brain barrier. Or you can have infection or transcytosis through the microvascular endothelial cells and other components of blood-brain barrier. There is a new theory called Trojan horse mechanism. Access to central nervous system through blood-brain barrier can occur by expressing angiotensin 2 enzyme in vascular endothelial cells, or by infecting the leukocytes, especially monocytes, that cross the blood-brain barrier. It is called Trojan horse mechanism. That means SARS-CoV virus can infect lymphocytes and monocytes near the vessel, and this is a tricky mechanism called Trojan horse mechanism. Through the olfactory route, the initial culprit is the sustenacular cells in the olfactory epithelium. That is the reservoir of COVID-2. Also, the basal cells and also the olfactory ensheathing cells within the lamina propria can also be infected by COVID-19. Now, this is the olfactory bulb. This is the olfactory epithelium. Now, the virus may enter the olfactory bulb transneurally, transcribal route, from via the axons of the olfactory receptor neurons. This olfactory epithelium and olfactory bulb here. And olfactory tract is this one. The lateral side of the olfactory tract really goes to the primary olfactory area. Now, the primary olfactory cortex is the piriform cortex, amygdala, and also the entorhinal cortex. The secondary olfactory cortex is insula and orbitofrontal cortex. You can get somatic symptoms, you can get pain, you can get taste sensation, and sometimes in dyspnea, even they cannot have the feeling that is insula is responsible for that. COVID entry and disaster. I have already told you about the circumventricular organs. These are initially it is by the transneural route, but it can also enter in the circumventricular organs. That means it need not cross the blood-brain barrier because there is no blood-brain barrier. That is in subcortical organ, paraventricular nucleus, solitary tract, and rostroventral medulla. Solitary tract is here. You can see the solitary tract, nucleus tractus solitarius. Here, lack of blood-brain barrier makes the CNS whites vulnerable. What are the neurological manifestations? Systemic review and meta-analysis in 2021, out of the syndrome, maybe encephalitis, acute disseminated encephalitis, which many times was hemorrhagic or even myelitis. You can get ischemic strokes, half of them with pulmonary embolism. Peripheral neuropathies, including Guillain-Barré variants, including Miller-Fisher syndrome and brachial plexopathies. Miscellaneous include ataxia and other isolated cases. Most commonly reported neurological symptom, more than 10 studies, more than 1,500 reports, fatigue, 13.2 percentage. So here you have to think of the involvement of insula also. Dyspnea, 26.9 percentage, myalgia, 16 percentage, headache reports vary, 9, even 15, some people say. Nausea, sometimes you can get it. Sporadically reported symptoms include anorexia, malaise, dizziness, and confusion. This is from the BMC neurology.
You have 3 more minutes.
I don't think so. I will be able to complete. I will go fast.
Okay. No. Okay.
You can
so five,
have
five, 10, 8 minutes.
A direct invasion can produce anosmia, acheusia, meningitis, encephalitis, myositis, vasculitis, including stroke, hypoxia, and hypoxic-induced hemorrhagic encephalopathy. Hyperinflammation can produce encephalitis, hypercoagulable state, and venous thrombosis, multi-organ failure, hypoxemic, or other encephalopathy. Immune-mediated, you can get ADAM, acute necrotizing encephalopathy, Guillain-Barré, and Miller-Fisher. Recently, there is a neuro-COVID staging, stage 1, 2, and 3, and the last stage is the blood-brain barrier damage, delirium, encephalopathy, and seizures. And most of the patients will have renal dysfunction at this stage. There in the FTG PET, they have told there's hypometabolism, especially in the prefrontal insular and subcortical abnormalities, and prefrontal cortex, anterior cingulate insula, and coordinate nucleus that may be responsible for chronic or long COVID manifestation, including encephalopathy, mild cognitive impairment, anxiodepressive symptoms. Insular dysfunction may count for deregulation of respiratory failure symptoms. Post-COVID neurological syndrome, you can get, which I have already told you, myopathies, you can get it, and 97% had PTSD. Chronic neuropsychiatric issues, neurodevelopmental disorders, depression, PTSD, and cognitive dysfunction. And 40% PTSD, depression, OCD, and equal incidence of anxiety disorders. Meta-analysis, they have told MCI is reasonably common. Maternal immune activation may play a role in producing autistic spectrum disorder and schizophrenia, probably. Suicidal vulnerability may be because of neuroinflammation, also many of the psychosocial factors. Because of the time constraint, you can go through the current psychiatry report 2021. There's a term called brain fog, feeling of brain being mentally slow, fuzzy, spaced out, maybe because of the microstructural changes in hippocampus, hypometabolism of PF prefrontal cortex, anterior cingulate, insula, caudate nucleus, and unusual cells in the capillaries called megakaryocyte. That's the reason for it. And neurological symptoms, even after 3 months after that, also mood changes, fatigue, headache, and visual hallucination. Attention and executive dysfunction. In one report, it's called 85%, so long COVID. MCI, depression, fatigue, stress, anxiety, psychosis, maybe. I do have my explanation, neural circuit explanation. Because of the time constraint, I will skip it. Only 2-3 minutes. Mechanism, anosmia and adousia, disruption of chemoreceptors by invading olfactory mucosa, anosmia, adousia, viral replication, solitary tract nucleus, and also retrograde transport of virus from the gustatory receptor cells in the tongue. This I will skip it. Nucleus tractus solitarius mechanism, myalgia and myositis, activation of cytokines produces vasculitis and myositis, viral interaction with angiotensin converting enzyme to receptors on muscles, or virus-induced type 1 interferonopathy. Dyspnea, basic area is lateral brachioplex, parabrachial complex with many afferents. I will skip this slide. And this also activation of pulmonary efferent neurons, and carbon dioxide chemoreceptors can produce dyspnea. Disconnect between the control of breathing and respiratory sensation, that is basically insula, is involved. This is ventral respiratory group. This is the Pondian respiratory group, controller respiration. Dorsal respiratory group controls mostly inspiratory movements and limits. Now, COVID has spread through the brainstem via olfactory bulb and orofacial sensory fibers via cranial nuclei. Chemoreceptors can detect changes in the blood pH, and it can affect the involuntary respiration. Medulla sends signal to muscles that initiate inspiration and expiration, control non-respiratory air movement reflex like coughing and sneezing. Even myositis can aggravate all these places. These are the breath-related signals of olfactory origin project to hippocampus, prefrontal cortex, and insula likely affected. It can impact distinct sensation, acute lung injury, pro-inflammatory cytokines can produce dyspnea and tachypnea. Hypoxic encephalopathy, 20% of the patients, and prolonged hypoxia, this is the autopsy finding, and cardiovascular and cerebrovascular events, formation of blood clots in the cerebral veins can result in cerebral vein thrombosis. Higher levels of angiotensin 2 are associated with vasoconstriction, and this vasoconstriction can contribute to the rupture of blood vessels in the brain, and cytokine activation, hypercoagulation results in the formation of small and large vessel occlusion in cerebral arteries. Damage to arteries in the meninges can result in meningitis, and also cytokine excess can damage blood-brain barrier and damage neurons and glia that will produce seizures or encephalopathy. These are the last two slides. Guillain-Barré syndrome and Miller-Fisher, you can get it because of the immune-mediated molecular mimicry, that is cross-activation of autoreactive T cell or T cell by pathogen-derived peptides, trigger the formation of the autoantibodies, GD1A in Guillain-Barré variants also. Mechanism of nerve damage may be primarily facilitated by T cell activation and release of inflammatory mediators by macrophages. Take home an overview of the COVID-19 virus, pathways, neuroinflammation, invasion, neurological manifestation was attempted, mechanism to explain neurological syndrome outlined. Thank you very much. Sorry for crossing my time limit. Thank you. Okay, Anugan, back to you. You are muted. Anugan, you are muted. Muted. You are muted.
Oh, I'm still muted. Okay. Yeah. Thank you very much, Mon, for a very clear and concise, detailed, and exhaustive presentation. So, without further ado, I know a lot of people will have a lot of questions. Kindly keep it relevant to the presentation and relevant to the topic, and post it in the question answers. And can I now request Dr. Rajesh Nagpal to come and enlighten us about this schizophrenia, which is resistant from the times of Kreplin. It has been described as a chronic, progressive, debilitating disease. So, Dr. Nagpal, please.
Thank you, moderator, sir. Thank you, co-speaker, Dr. Mohandas. On the event of World Schizophrenia Day, I often present this slide. It's from the Canadian Schizophrenia Society, talking about occurring in all races, all cultures, and can be treated but not cured as yet. This is a reality check for all of us. So, I wish to bring about, my topic is the Clozapine paradox. Waiting for Godot. It's a French play by Samuel Beckett. It's a tragicomedy in 2 acts. So I'll make a couple of statements here, some of them categorical. If you treat schizophrenia, you must prescribe Clozapine. This is addressed to my younger friends. Now, importance of being Clozapine. A specific protocol is used for the administration of Clozapine, though it is not mandatory as per Indian regulators. Evidence points to use as gold standard in treatment-resistant schizophrenia. Moderate evidence for suicide risk in schizophrenia. Off-label use for psychosis in Parkinsonism, dementia-related psychosis, tardive dyskinesia, resistant mania, and childhood schizophrenia. So my case for Clozapine. Clozapine is the only evidence-based effective treatment for TRS, as reflected in international guidelines, with reported clinical response 60 to 70% of patients and meta-analysis identifying an overall response of 40 to 60%. In naturalist settings, compared to no antipsychotic treatment, Clozapine associated with decreased rehospitalization, reduced hospitalization, and reduced risk of relapse. Its use is associated with reductions in comorbid substance abuse, use, hostility, and aggression. What are the ethical and medico-legal arguments for use of Clozapine in treatment-resistant schizophrenia? The prevalence is 20-30% of schizophrenia patients respond inadequately using the strict Kane criteria or clinical criteria for treatment resistance. We know the Kane criteria that that they're resistant to at least 2 trials of antipsychotics. Clozapine response rate in rigorous studies are 40 to 60%. Response rates to other antipsychotics in rigorous studies are less than 5%, olanzapine 7%. The ethical issue is only Clozapine works. Hard to justify trying something new when there is no evidence of effectiveness in TRS. I mentioned in this context are repetitive, irrational polypharmacy in psychosis. The medico-legal issues. Sites like clinics, offices, jails, prisons that have persistent patterns of low or no Clozapine use are at risk of successful lawsuits based on the right of standard of care or damage related to adverse outcome, example, suicide, self-harm, and assaults. So many of our homes, old age homes with psychosis, young children with psychosis, prisons having psychosis, we require to use Clozapine little more than now. That's the case, else we run into problems. Now, some of the problems which have led to the discreditation of Clozapine in TRS are because of sloppy conclusions, sloppy design leads. Clearly, Melzer's study, the rigorous TRS definition by Kane requires failure of 2 prior antipsychotics and a prospective trial of high-dose typical antipsychotic therapy. The Melzer 2008 study is typical of many studies. No prospective trial of an antipsychotic led to extremely high response rates for olanzapine, not seen in studies using all Kane criteria. So that whole issue of olanzapine being as good as Clozapine does not hold water. What is the economic argument for using clozapine in TRS? In US, obviously studies are from the US, I'm sorry for that. US 2013, total direct healthcare cost, direct non-health costs and indirect cost $155.7 billion, unemployment 38%. Annual costs for TRS patients are 3 to 11 times greater than for other patients. Hence, there is a great need and a great urge to use clozapine for TRS. We saw that clozapine use is also associated with lower all-cause mortality, less suicide and less self-harm, irrespective of the side effects of that. An important meta-analysis, Vermeulen et al. 2018, identified that those continuously treated with clozapine had lower all-cause mortality over a 7-year follow-up compared to those continuously treated with other antipsychotics because of the risk of suicide, which was a great factor. Another case for clozapine. Clozapine effective in 32% of TRS cases. Number needed to treat are only 5. In producing clinical improvement short-term studies. Despite debate as to whether and by how much SGAs are better than FGAs, clozapine remains clinically better than all treatments to date for TRS. We understand it's got a unique receptor profile. It's a 5-HT2A 2D antagonist with antipsychotic properties, which mechanisms action based on the inhibition of D2 receptors in the mesolimbic pathway and the 5-HT2A receptors in the prefrontal cortex, thereby reducing symptoms. We also know it's also effective on the D3, D4, and D5 receptors. We still don't know what happens there, but we know it's effective there. The drug also acts on the histamine, alpha adrenergic, and muscarinic receptors, which mediate its antipsychotic and metabolic effects, much to our dismay. One of the many lessons that COVID has taught us is the value of common sense and experience. Among the rash of repurposed drugs, HCQS, ivermectin, drugs with low quality medical evidence, the remdesivir, wrong timing of drugs, example steroids in the first 5 days, plasma and the tocilizumab, which do not pass scientific muster. What worked is the paracetamol, the oxygen steroids in precise dose at the precise time. In a similar sense, clozapine at the right time, at the right dose will help. Antipsychotics, can we handle the truth? It is worth reflecting in the Indian context on how crudely we often use antipsychotic drugs. Polypharmacy, the prescribing of 2 or more antipsychotics, I am also to blame. In parallel, it's widespread despite the lack of evidence to support it and the knowledge that it doubles cost and multiplies safety risks. Off-label prescribing is common in the context of severe chronic illness. Clinicians are tempted to resort to untested measures, for example, combining olanzapine and clozapine or combining risperidone with the olanzapine. This sense of frustration allows us to be beguiled by the promise of a new class of drugs. We keep on looking at the horizon for a new drug coming. These trials, KT and Cutlass 1 and 2, again emphasize the need for us to use our existing treatments as well as knowing how to use existing treatment and rather than finding out new safe effective medications as well as knowing how. So why not use what we have more effectively than keep on looking in the horizon for new drugs to come. Now we understand that in the time of major psychotics, the clozapine came in 1970 and 1988 it finally got recognition after a long period and all of us are familiar. Now, clozapine for TRS, this is a double-blind, this is a famous study in which showed very clearly that these were difficult patients who had had at least 3 different epileptic trials, and they were now put on haloperidol, and they had failed on trial haloperidol, and then they were compared with the chlorpromazine and very clearly showed response. So, where are we today? So far, the only major advance in drug treatment for schizophrenia has been the discovery of clozapine, which has been consistently shown to have a superior efficacy in patients unresponsive to other antipsychotic drugs. No other agent developed since clozapine has shown equivalent efficacy, and the improvements over first generation antipsychotics have been incremental at best. So we know this whole controversy, and as amplified by the KT study and then Cutlass 1 and 2. So I bring you the story of the famous, is supposed to be the best play of the 20th century by Samuel Beckett, Wait for Godot, where 2 characters wait for Godot to arrive, who's going to give them salvation, and 2 people come, and then somebody else comes, but Godot still doesn't come. So it's like this, that we are waiting for Godot, we are waiting for a magic drug to cure schizophrenia, while we already have clozapine, which is at best a magic drug. So we now need to make the best of what we have. We need to look for more efficient treatment strategies and consider earlier evidence-based use of clozapine. This is my case. And that's the famous Samuel Beckett's Absurdist play. The two main characters, Vladimir and Esteban, wait endlessly and in vain for somebody called Godot to arrive. So, Beckett's play has been interpreted as a metaphor for the futility of man's existence when salvation is expected from external entity and the self is denied introspection. So we need to look within ourselves. We have Clozapine there since 1980, approved in the market. Why not 1988? Why not use that? So Act 1 is trajectory of treated psychosis, and the Act 2 is the curious case of Clozapine and orphan drug. So this is the whole analogy of Godot. So in Act 1, switching antipsychotics early, there is accumulating evidence contradicting one of the enduring myths of psychiatric practice, the delayed onset hypothesis of antipsychotic action. Many of us grown up with the idea that it takes time for the drug to act. Emerging research evidence suggests the absence of significant response to treatment in initial fortnight predicts subsequent non-response in patients with schizophrenia. This is very important, that we are now beginning to change our attitude. First 15 days, nothing happening, think of changing, think of increasing the dose of the drug. Act 2, early recognition of treatment resistance, the timely initiation of Clozapine. The curious case of Clozapine, an orphan drug. Clozapine is often referred to as a gold standard for the treatment of schizophrenia, and yet has been described as the most underutilized treatment for schizophrenia, supported by solid evidence-based medicine. We understand the pharmaceutical journey. After 30 years, Clozapine is still the best treatment. There is still fear among some clinicians about prescribing Clozapine for treatment of schizophrenia. Nearly half a century after it was introduced, the first atypical antipsychotic Clozapine has yet to reach its full potential. In the early 1970s, many psychiatrists questioned whether it could be even a neuroleptic agent because of its lack of experimental side effects, and we know it was discovered in 1956, and this is where it got recognition followed by the famous Kane study, and it was reintroduced in 1990. So the Clozapine paradox is that you have good solid evidence but decreasing use. Even as the evidence of the single efficacy of Clozapine, a broad spectrum antibiotic, grows and antipsychotic grows, its use is increasingly appeared mired in fear-based clinical superstition. It's the only antipsychotic approved by the US FDA for the management of suicidality in those with schizophrenia, schizoaffective disorder. And there is robust evidence indicating effectiveness in aggression and substance misuse. That, of course, is off-label. So I would like you to look at Clozapine, especially my younger friends, without blinkers. Although many patients with Clozapine fail to respond adequately to trials of 2 or more antipsychotics, the utilization of Clozapine for these patients remains low, despite recommendation for its use by accepted treatment guidelines. Some experts estimate that 5 to 10 times more patients could benefit from Clozapine than those who are receiving it. Learning how to manage the unique side effect profile of Clozapine can potentially remove barriers to prescribing this agent and thus unlock its unique therapeutic efficacy for more patients. I bring you an example from real life. We run Anvita, which is India's biggest women rehab center. Our center is full of people who have both a low IQ and, of course, severe mental illness. And we have been using low dose Clozapine and effectively able to control them so that we can render some kind of therapy to them. What psychiatrists find problematic about Clozapine? So Danish psychiatrists showed that the biggest problem was weight gain, the hassle of blood monitoring, agranulocytosis, the sedation, the hypersalivation, cardiac issue, and a rebound psychosis, in that order. What are the barriers to adopting Clozapine by psychiatrists wishing to avoid side effects, wishing to avoid blood monitoring, not knowing how to manage side effects if they arise, not knowing when termination treatment is warranted or can be avoided, and not knowing when to re-challenge after adverse effects? I can cover this briefly, of course. So removing barriers to adopting Clozapine by each one of us, learning how to avoid or manage key side effects, including when to continue, to stop out or to re-challenge. And the major problems, as we know, are the ileus, paralytic ileus, or the constipation, blood monitoring, agranulocytosis, neutropenia, or eosinophilia, the weight gain, and the onset of diabetes, myocarditis, QTc prolongation, tachycardia, NMS, and hypersalivation or siluria. So despite its superior unique effectiveness in TRS, there is marked geographic variation in prescription of Clozapine, which in most countries prescribed to far fewer than the approximately 30% of patients who are likely to benefit from it. In the Indian context, is 12.7% only. That's a very sad figure. It's something like we are using the injectable atypicals also in a very low figure. So what are the Points in favor of us aggressively handling or using clozapine: superior efficacy for psychotic symptoms, superior efficacy for TRS or TRP, superior efficacy for aggression. While all this is evidence based, superior efficacy for reducing suicide. We are aware of the Intercept study: low or no EPS, low or no hyperprolactinemia, low or no TD, and can even improve TD in the initial stages. Use in Lewy body dementia and use in Parkinson's psychosis if pimavanserin failed. If the pimavanserin fails. We know that clozapine saves life. Meta-analysis of 24 long-term mortality studies, more than 52 years follow-up, and mortality is highest in the period after clozapine, that is continuation, and that is the FDA has approved it as a single agent in psychosis to reduce the suicide risk. And that's the study by actually Melzer, where the effect of olanzapine clozapine is the same as far as symptoms concerned, but in suicide attempts and hospitalization prevent suicide, the clozapine outruns the Zyprexa or the olanzapine. Other uses for clozapine, as I said, is persistent aggression with psychogenic polydipsia, treatment-resistant mania, and Parkinson's disease psychosis unresponsive to pimavanserin. Now, response rates to clozapine in double-blind controlled studies of TRS. Remember, the first study was an inpatient refractory patient. Second study, again, a very small sample size, outpatient, partially responsive, and then outpatient refractory. And the drug for comparison was chlorpromazine, haloperidol, and haloperidol. The problem is that most of the evidence for concluding that clozapine is convincingly more effective than typical antipsychotics in reducing symptoms of schizophrenia relates to hospitalized patients, but the future use of clozapine will be predominantly community based, and this is important in the Indian context too. So what Katie did was showed that clozapine is effective in negative symptoms. In Katie phase 2, clozapine emerged significantly more effective in patients where other drugs had been inefficacious, with twice the time to discontinuation, 10 months, compared to the next best olanzapine. So that is what Katie showed very clearly: efficacy when comparison to olanzapine and in negative symptoms. What Cutlass 1 and 2, the studies from Europe showed: FGAs, if carefully prescribed, are as good as most SGF, second generation antipsychotics, in many if not most patients with established schizophrenia, with significant advantage only for clozapine. So the verdict is out, the jury is out, that FGA, SGA is the same, except for clozapine. That is the exception. Fact sheet: while prevalence estimates of TRS vary, suboptimal response is reported as many as 1/3 of patients, 30%. Prescription rates for clozapine range between 1 to 1.8%, with perhaps only 14% of those eligible actually receiving the drug. And that is the irony, that is a paradox. Irrational, non-evidence-based antipsychotic polypharmacy, like combining trifluoperazine with risperidone, is the most commonly used alternative, even as it will worsen side effects and contribute to treatment resistance. And we are aware of these prescriptions of 25 milligram of say quetiapine, 50 milligram of say 5 milligram of the aripiprazole, 5 milligram of the trifluoperazine, and 2.5 milligram of the olanzapine. It's a very common prescription based all over India. It gets even curiouser. Just like in the case of the long-acting depots, willing patients and reluctant psychiatrists like me, 87% of patients on clozapine surveyed feel its advantages weigh any disadvantages. Psychiatrists are reluctant to prescribe because they think patients would not like it. This negative attitudes, which contaminate trainees as well, are linked to limited knowledge and experience. The pernicious self-perpetuating cycle is nurtured by the pharmaceutical industry's apathy toward this generic orphan. It's also called the orphan drug in psychiatry. A 11-year follow-up study of mortality in patients with schizophrenia, population-based cohort study, showed the introduction of SGAs of the second generation antipsychotics in the 1990s, starting with clozapine as the first one, is widely believed to adversely affected mortality of patients with schizophrenia. The aim was to establish the long-term contribution of antipsychotics to mortality. The interpretation was long-term treatment with antipsychotic drugs associated with lower mortality compared with no antipsychotic use. So definitely antipsychotics help. Second generation drugs are a highly heterogeneous group. You have the risperidone, you have the olanzapine, you have the paliperidone, etc. And clozapine seems to associate with substantial lower mortality than any other antipsychotic. Therefore, we need to address the restrictions on the use of clozapine by ourselves. So this is also a 5-year follow-up study from the Finnish thing very clearly that while antipsychotic use has been associated with decreased mortality due to suicide in this study, clozapine was the only second generation drug and was the first atypical associated with lower likelihood of suicide as noted in several earlier studies. Once again emphasizing the importance of suicide. And again we are seeing the comparison 5-year mortality, 5-year suicide where clozapine registers the best. Clozapine balancing safety with superior antipsychotic efficacy, again by Melzer, can be estimated from the effects of clozapine on at least one-third, approximately 5,000 patients per year with schizophrenia schizoaffective who will commit suicide in the US would not do so had them treated with clozapine. So that is the crying issue, that if we treat more patients, we can prevent suicide and schizophrenia, which we know is a horrible outcome. Now the whole issue is regarding monitoring white blood cell counts. Long-term monitoring for white blood cell counts internationally is patients, not in India of course, more than 5,000 patients would need to monitor to avoid one death. The incremental cost benefit ratio were at least US dollars 970,000 per quality adjusted life year gain for all 4 strategies compared with no monitoring. So now the interpretation is that existing strategies for monitoring white blood cell count of patients taking clozapine based on divergent national requirements do not seem to be cost effective. So now we need to change it, and let me see what. So clozapine, a review of clinical practice guidelines. Clinical practice guidelines, however, do not appear to be followed by prescribers, and clozapine remains an underutilized medication patient treatment. So though you have algorithms in favor of clozapine as a gold standard, people are not using it sufficiently, and that is the paradox. The present evidence does not link clozapine to increased mortality rate. Indeed, it appears to be better than other antipsychotics in this regard. Clozapine is routinely positioned as a third line treatment of schizophrenia, but in light of existing evidence, this warrants a re-examination. Clozapine and LAIs, as I said, were associated with the lowest risk of all-cause hospitalization in both the cohorts. Clozapine and the LAIs are the most effective treatment in preventing psychiatric and all-cause hospitalization among chronic and first episode patients with schizophrenia. So, like the LAIs, clozapine is also not used, though you have got huge evidence in this support, and I am quoting the evidence here. So, clozapine, according to Farooq and Taylor, is a dangerous orphan or neglected friend. Evidence concerning the superior efficacy and effectiveness of clozapine has not fully informed routine clinical practice. So in Indian context only 17%. This is possibly because of perception that clozapine is a dangerous therapeutic agent. Clozapine use may actually promote longevity, and earlier use of clozapine adequate dosage represents a neglected therapeutic opportunity in this age of stagnated antipsychotic innovation. So we don't have to wait for Godot. We should start using clozapine in the right patient. So in conclusion, the first part, clozapine has demonstrated better efficacy and effectiveness than any other antipsychotic and useful where it concerns suicide, aggression, and comorbid substance abuse. Despite these factors, clozapine remains, so in spite of a lot of side effects which we have seen, clozapine remains an important therapy option that can sometimes transform an individual's life. Clozapine should not be considered treatment of last resort, but a drug of first choice as soon as you have non-responsive. I am not suggesting it's a first-line antipsychotic. I am saying it's a first choice when the person begins not to respond. Now, this is a very interesting study. This happened in Maudsley, suggesting very clearly that from the first episode to schizophrenia, if you delay the initiation of the clozapine, it will not work. So delaying it beyond 3 years from the time of TRS decreases the response rates. So among the 160 new clozapine starts at an academic site in actually Istanbul, Turkey, the mean delay was 29 months, and the extent of delay was an independent contributor to the odds of clozapine response. The Japanese analysis also says that a delay of less than 2.8 year response rate was 81.6. A delay of more than 2.8 years is response is 30.8. So the 2.8 or 2.7 appears to be a magic figure. Between the time of the first psychosis and 2.18 years or 2.8 years, we need to start the clozapine. Otherwise, it will not show the same response. So the earlier we start, the better, at least not beyond 3 years. That is the message here. So as I said, that clozapine and fewer pre-clozapine antipsychotic trials associated with better treatment outcomes. As I said, that the Japanese study showed very clearly to 8.8 years is one, and Angate says that emerging evidence suggests additional benefits with earlier use of clozapine exists much earlier than 2.8 years critical time identified. So try and use it before 2.8 years, not after. That's the message. Many people with TRS experience delays of 4 to 5 years before starting clozapine. Each non-clozapine antipsychotic trial before clozapine is associated with a further 10% reduction in clozapine response rates. Further, high-dose antipsychotic polypharmacy is used in 36% to 65% of patients before using clozapine. Based on the available evidence, clozapine should be used much earlier than 2.8 years critical time. So the pragmatic algorithm based on the BPRS is drug A low dose for 4 weeks. If an adequate response, you prescribe drug A full doses. If an adequate response, prescribe drug A high dose for 4 weeks. If an adequate response, you go on to drug B. Inadequate response, go on to full dose, and then you start clozapine at week 25. That is what the current algorithm should actually read. That by week 25, after giving a, as I said, we are going to now look at earlier response to antipsychotic in weeks and not months anymore now. And we change it accordingly, and then we go on to after 2 trials in adequate doses or in high doses, we shift to clozapine by week 25. That's what I'm suggesting. Is clozapine underused in India? As I said, we have a ubiquitous polypharmacy, delayed initiation. There is growing evidence that clozapine best started early than late. In treatment with clozapine in India is however delayed by almost 10 years after first contact compared to 5 years in the UK. Up to 13 antipsychotics have been tried before starting clozapine with a mean duration of illness of 15.1 years. That is the tragedy. So I have culled some experience that treatment of schizophrenia are usually initiated with atypicals in the absence of managed care and no price differential between conventional and atypical, which is the factor in the NHS or in the US. Most of the TRS patients are therefore at least 1 or 2 atypical resistant. So there is no rationale to my mind for switching to conventions at this stage. Clozapine, because of attending metabolic side effects and weight gain, is usually combined with aripiprazole low doses. Blood monitoring with clozapine is no longer mandatory in India, went out several years ago, and availability is almost OTC, making the prospects scary. Quetiapine is usually an add-on and rarely standalone in TRS. Combining conventional with atypicals is not uncommon. Combining 2 atypicals excluding clozapine is not uncommon, and we use ECT here far more than in the West. We have an earlier onset of metabolic syndrome, greater incidence of metabolic syndrome, increased incidence of treatment resistant, treatment emergent, OCS, inadequate symptom control, weight gain, sedation affect treatment adherence because of our metabolic factors. So my case up till now is start clozapine within 25 weeks or if the patient is not responding, go on from drug A to drug B, low dose, adequate dose, high dose, low dose, adequate dose, high dose, week 25 start clozapine before 2.8 years. Now a sort of potpourri on clozapine. Where to from here? So you switch antipsychotics in 4 to 2 weeks, avoid endless switching of polypharmacy, move beyond the myth of clozapine being the treatment of last resort, consider using early before chronicity sets in, recognize clozapine's vital role in the early treatment within 25 weeks of poorly responding first episode patients, monthly blood tests are redundant waste of resources, modify treatment guidelines accordingly. Now the important thing to remember is this interesting slide that in 1990 when the drug was compared to haloperidol, the non-clozapine antipsychotic options were by definition only from the class of conventional antipsychotics like haloperidol, chlorpromazine or trifluoperazine. So original study by Kane was for the most severe resistant group. So at that time in 1990 the clozapine criteria and selection was different. Now you touch base to 1995 when you have had now 2 or 3 new antipsychotics having come in like the risperidone. So after the person has not shown response, resistant, in this moderately resistant subgroup, clozapine was more effective than haloperidol, but then risperidone was almost as effective as clozapine. Therefore, alternatives to clozapine can be effective in middle group of treatment resistance. So those people who are moderate resistant, clozapine and risperidone may be the same. But for those who are treatment resistant, 30% of them, as we know, clozapine is the drug of choice. So in this category, moderate resistant, please think of other antipsychotics also, particularly the atypicals. That's what has changed in 1995. Now
2 minutes. 2 minutes.
Now you go on to the, okay, 5 minutes, please, you don't mind. So now the whole issue is here. The treatment resistant concept as a gradient is that today we are saying if there's a good response, sufficient response, avoid clozapine. The moment you have a minimal response, think of clozapine. Now monitoring clozapine, I'm not going to remember that the plasma level is 350 to 420 milligrams, and we are doing it in India. It's done by Quest Labs in the US, And we now standard protocol is weekly up to 6 months, every week from 6 months 12 months, and monthly thereafter. Identify those with benign neutropenia, which is in African Americans, and you require a point of care ANC testing. The important thing to do is now you only focus on the ANC. In the normal range ANC, if it is less than 1, if it is more than 1.5, treated as usual. If there is mild neutropenia, you continue treatment. And if there is moderate neutropenia, you can interrupt, suspect clozapine, and start hematology consultation. So now you have one point contact only of ANC. Now the point of care contact testing for ANC, I suggest the Alchem, who's the sponsor of the show, and the makers of Alkepen, please listen. ANC monitoring issues, venipuncture is actually very painful. So there's a solution. FDA approved device uses a 28 gauge. It's like using for the blood sugar. The report comes within 6 minutes, and we can use it as an office practice, and maybe Alchem Laboratories can start this process. So we understand there are sex-based differences. The women seem to be more effective, though we are not very sure. We are aware of this is outside of, but I'm aware. I just want to point out here that there's a huge area of work today on management of clozapine non-response. And the interesting aspects here, apart from the other antipsychotics, is that you treat comorbid conditions and also look at CBT. The augmenting agents, we have good evidence for amisulpride, some evidence for aripiprazole, and not much more for the rest. ECT in Indian context very important. Relatively high response rate of clozapine are not responding with ECTs, and that's interesting from our point of view. And interesting also is the fact that it works with CBT also. So evidence highlights clozapine as the cornerstone of pharmaceutical management of TRS. Clozapine is a uniquely effective medication with over half of those treated responding, with additional benefits in reducing suicide, aggression, violence, alcohol substance abuse, psychiatric hospitalization, and all-cause mortality. Despite there being no comparable alternative, clozapine treatment underutilized, initially delayed, hence the paradox. Increased evidence suggests it should be used earlier in the course of illness, 25 weeks after the person shows no response, with better long-term outcomes at least before 2.8 years. I end with Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. Thank you very much, sir, and the audience.
Thank you. Thank you very much, Dr. Nagpal. I'm sorry to have rushed you through a very important topic. We need to have constant appraisals and constant renewals of our knowledge about clozapine and how important it is. You have given a very comprehensive coverage to the whole data that we have from the beginning. Very thankful to you for that. I will now move on to the questions. Would you like me to separate the questions for you and Dr. Mohandas? First ask him and then you
answer all the questions. Dr. Mohandas is my mentor. He can answer all the questions. He's much better than he can answer it. I'm fine.
We are not. First question is from Dr. Ramesh Babu for Dr. Mohandas. No. Considering the QOL, quality of life and fatigue domains, by using PROMIS, patient reported outcome measurement information systems, and NIH toolbox, what is the best time to assess? It means after how many days of discharge from hospital or symptom free, and how frequent should we assess for better anticipation of brainstem involvement, neurological symptoms in long haulers of COVID. So from what I can understand, Dr. Mohandas, is he there?
Yeah, it is a speculative answer. Whatever the studies are there, usually they do after 3 months evaluation. We have got statistics. Even after 6 months, we have got statistics. Right. COVID is a new entity and people are now coming out. But sooner than later, we will have more MCI data, which is coming, which we haven't got it. And similarly, the data which are turning up, that is why there is a variation in the percentage. I have not, very recently the article has told that at least 87% after 1 year, I mean, not 1 year as such, 9 months to 1 year, their psychological assessment suggested there's attentional problem, there are executive problems, etc., neuropsychology. So
Executive functioning
probably
effects.
executive function, especially because of the prefrontal cortex involvement. That is what
Right.
they have told. And
Right.
emotional variation because of the orbitofrontal cortex involvement, and
Right.
because of the attentional problem because of anterior cingulate, and your chronic somatic symptoms because of the insular
Getting
impairment and
affected.
functional these things. Okay, these are the ways, but it is too early to say how often that you have to do it. After 3 months, again after 3 months, 6 months, then 1 year, then we will get the data. So far, so
By
whatever
the
data is available, I have answered.
by that time we would probably be updated more on uh, what is the format. Dr. Darpan Shah has asked a question to Dr. Rajesh Nagpal. Is it advisable to cross titrate with other antipsychotics in all the patients who are stable on clozapine but not vaccinated for COVID-19 because of increased risk?
Not necessary.
Dr. Nagpal?
Not necessary.
Okay. Dr. Dr. Srinivas Chakravarti has asked, is the rate of infectivity proportional to the rate of mutants? Mutations. Could be
Mutants.
mutations.
Yeah, infectivity
Mutants, yeah.
is more with the mutants, and the severity, especially the mortality and severity in some of the mutants, and why it is so, we do not know. The clinical presentations are also different with the mutants. For example, you do not have fever in some of the mutants, but instead you can have a silent hypoxia and you can come there. You can silent hypoxia, the patient may not feel also regarding that you are dyspneic. So the symptoms may be completely different. Sometimes recently, earlier it was called that headache is very low percentage. Now it is coming up. So with the mutants, the symptomatology may differ. The severity depending upon the mutants. For example, the UK variant and the South African variant is not even responding to many of the vaccination strategies. That is what the current finding. The South African mutants, they may escape from the vaccination, but we have to have the data from the double mutant and the triple mutant. We do not know.
Right. Okay. Dr. Challa Bharti has asked a question that there are some COVID survivors who, even after 6 to 8 months, are suffering from occasional dip in SpO2 concentration to as low as 84 to 88 at times, and also tachycardia with minor activities. But their CRP, D-dimer, LDH, etc. are normal. What do you attribute this to?
Answer is very simple. It is not acute, but it is chronic. CRP energy is not infection. But basically, it is the insula dysfunction and nucleus solitarius dysfunction, especially. I don't have time to discuss much on the brainstem respiratory structures. So there is a dysfunction. That is a possibility. Uh, uh, that is a possibility which is told about insular deregulation for the respiratory failure in those chronic patients. Also, the connectivity with the nucleus solitarius and other dorsal and ventral, because nucleus solitarius comes in the dorsal respiratory group. Even the ventral respiratory group are also involved. That is the explanation that is being given for this.
Okay. Thank you, Doctor. Srinivas Chakravarti has asked why most people are not aware of the hypoxemia and are also called happy hypoxemia.
It was called happy hypoxemia. That name is wrong. It is a silent hypoxemia. And why it is not being sensed is basically the insula and orbitofrontal dysfunction, which I have already told. They have a disconnectivity because they may not feel that they are having it because insular dysfunction. That is the reason. And it is called silent hypoxemia and even hypoxemic encephalopathy. It is not happy hypoxemia. People earlier it was called. Now they have told that you should not use it happy. Basically, it is unhappy because that is not a good signal.
Right. Rajesh Jain is asked, can antidepressant prescription help in reducing symptoms of long haulers syndrome?
What is long?
Can antidepressant prescription, use of antidepressants, help in reducing symptoms of long haul COVID?
It is a theoretical possibility, especially for depression. But there were some reports that it has got prophylactic effects against COVID and nothing. Some reports on fluoxetine, etc. These are all questionable one. But depression as a neuroinflammatory process, which can be there in the post-COVID, apart from the psychosocial reasons. So it may be helpful in long COVID, especially depressive part of it, because it is not only neuroinflammation but oxidative stress also. That mechanism explains it.
Right. We have Dr. Jitendra Nanawala, who's asking, long COVID neurobiology is because of inflammatory response or due to thrombosis in brain vessels? I think you already answered that.
Already not only chronic neuroinflammation, but in cerebrovascular thing, it is thrombotic phenomena.
It is both.
And also oxidative stress. Also oxidative stress.
Yeah. Okay. Same Dr. Jiten Nanawala has asked Dr. Nagpal, will you start Clozapine for the first time in patient with COVID?
Dr. In Nagpal? COVID, no. Intra-COVID, yes. I mean, long. I have begun the drug in the period of long COVID, but not when they had the COVID, the first 14 days.
Okay. Dr. Sagnik Banerjee is asking, would like to know about new drugs of choice in schizophrenia. Dr. Nagpal?
Nothing much.
Just enumerate them.
Yeah. The pipeline is dry, so the one that we're expecting is actually brexpiprazole, which is like ariprazole, and you are going to have cariprazine coming to Indian
country.
And pemavrine for the Parkinson psychosis.
And lumateperone, which is lumateperone.
Yes.
Yeah. Okay. Dr. N. Balasubramani is asking, which is the best drug to treat clozapine induced tremors? Best strategy to treat myocarditis?
So that was an area which I didn't want to talk about, but there is a clear-cut guidelines today. Myocarditis, what they are saying is that if it is an ROI, that means you don't need to stop the clozapine straight away. You can reduce the dose of clozapine. You need a proper. Now we are suggesting that when we initiate the clozapine in actually older individuals, please do a complete cardiovascular workup so that it actually helps, because it's going to continue for life. In those who are already having, we only need to reduce the dose of drug and treat the cardiovascular problem separately and actually aggressively. Stopping the drug is not the answer generally.
And clozapine will improve tremors rather than reduce tremors.
Right. So tremors is not part of the clozapine thing anyway. So EPS is almost non-existent. We know that.
Okay. So Dr. Orela Ramana Rao has asked, clozapine being notoriously linked to agranulocytosis 8% of users. Are we justified to use in new patients as well as those who are already using and become positive for COVID?
See,
what it means is that they're asking, should we start in new patients or should we discontinue patients?
No, as I said, it is a...
Are we justified of its use? I'll just repeat the question to you. Are we justified of its use in new patients as well as those who are already using it when they become positive for COVID?
During the 14-day period when a person is on clozapine and has developed COVID, I will only request a blood monitoring done thrice a week. After the first 14 days, it is of no consequence, just another antipsychotic, and still used to using it.
Rajesh, can I add it?
Yes, please.
Can I add it?
Yeah.
In the acute syndrome, clozapine you have to use with caution. there are enough guidelines. We have already written on COVID psychopharmacology. We had presentations also. And but as he has rightly told, long COVID, if there is a need, clozapine can be used
Continue.
with a rational care. How you know the rational guidelines, but acute COVID for the time being, no.
Okay, Ram Krishnam Raju has asked, now his question is in two parts. Is long COVID due to inflammatory process or virus particle entering the microglia? What are the effects on a person who is already on clozapine and takes vaccination? Is there a difference in effects between Covishield and Covaxin?
Uh, uh, very good question. But the problem is, it is not the microglial activation is the initial thing. Okay, what
Only
are
the
the mechanisms? And acute A1 cytokine storm, etc. Now, after that, long COVID is different. Long COVID, there is already an impact of it, be either because of the cerebrovascular events. Nanawala has already asked,
admit.
has asked about the thrombotic, even microinfarcts in the brain, especially in the hippocampus, and hypometabolism in the prefrontal cortex, anterior cingulate, insula and caudate, and also the oxidative stress mechanism. And that is what is happening in the chronic COVID. So it is microglial activation, etc. is initial stages. You can get it in any infection. Okay. And any other answer, any vaccine. Vaccines are very difficult to interpret. We can have sessions on it, the comparison between, among the many vaccines available. The protection in the COVID shield is 70 to even 80% say if the spacing is more than 12 weeks, now they say, but whether it is because of the non-availability or whatever thing, we do not know. Earlier, it was told that even between for 4 weeks to 8 weeks, within that period, you have to give it. Now you can even extend to 12 weeks. You will have more protection, some people say. But whatever the vaccines are given, doesn't mean that you will have 100% up and free from the illness. You can get the illness. Severity may be less. But some of the mutants can escape this thing that we are yet to know. For example, the South African variant we have told, and some of these vaccines may not be effective in all the mutants. We are yet to see. In the further waves, we'll know.
Right. There are loads of other questions. We'll have to be quick and short answers. Dr. Colin Braganza has asked, what should be the approach for a middle-aged client, 45 years, known case of TRS, maintaining well on 300 milligram of clozapine per day for 10 years, being treated for diabetes with metformin, develops myocardial infarction? Would it be prudent to continue clozapine or taper and consider alternative drug? If family have no preference after psychoeducation, request doctor to do whatever doctor feels best. Dr. Nagpal?
I would prefer to reduce the clozapine. I would like to do a plasma clozapine level. A plasma clozapine level, I like to aim for about 250 or so. I like to add a drug like aripiprazole or the amisulpride in low doses for as a combination, but keeping the plasma clozapine level into consideration.
Thank you. Vishnu Padasaha is asking, what makes clozapine so effective compared to other in treatment of resistant schizophrenia? What is the second best antipsychotic in treatment resistant schizophrenia?
According to evidence-based medicine, after clozapine is actually olanzapine, which is almost a similar family, but that is evidence-based medicine. In real life and in the case studies, everything is same except clozapine. Clozapine seems to be more effective only in treatment of schizophrenia, not for the moderately resistant. Any of the SGAs are as good or bad, including clozapine.
Dr. Ramesh Babu, if you observe the brainstem related neuropsychiatric complication observed in the beginning of COVID, I suggest to include psychiatrists in the treatment team from day one for better outcome. And to prevent post-hospitalization neuropsychiatric polyp. What is your suggestion in this regard, sir?
It's up to the COVID management team and your hospital, the thing.
Absolutely.
Psychiatrist
Dr.
is not going
Nanavala
to
is
do
asking.
anything.
Dr.
He is not
Nanavala.
going to do anything in the first thing.
Dr. Nanavala asks, can you prescribe it to patients with persistent tachycardia of 120 per minute?
What? Clozapine?
Yeah.
You do the QTC interval. If it's fine, there's no problem.
Dr. Paresha is asking, post-COVID laryngitis or hoarseness of voice, which lasts longer than 6 weeks in many patients, increase with stress. Any relationship with brain COVID virus and laryngitis? No response to routine treatment.
Yes, especially after this year because of neural correlates, which I told you, it can produce in one or two slides. I have already mentioned this in the respiratory path. It can produce chronic pharyngitis, even laryngitis type of symptoms, hoarseness of voice as a neural complication, and we can be exacerbated by comorbid anxiety, etc. That is anybody you can do it, but otherwise rarely you can get it. There are reports of this thing in the long COVID.
Okay. Dr. Rohit Kothari has asked, sir, do you suggest the use of long-acting antipsychotic with clozapine in view of compliance, which is almost always there in mental health patients?
In select cases, yes. As a general rule, no.
Okay. Dr. Chalavati, we can't help but prescribe 3 drugs too in many cases of TRS, including clozapine. Unfortunately, there are some cases where they are still resistant. How far can we go with clozapine dosage?
Take the blood levels. See, the reason is that between 250 and 350, some people do even good with higher level also. But I would suggest in Indian context, from our own limited experience, above 350 usually is not much benefit. So please take the help of blood level when you want to monitor the dose and go on to doses like 1000 milligrams or plus.
Dr. Ramesh Babu asks, we pretty know that there is possibility of intoxication of clozapine in COVID state, but symptoms of intoxication are not seen in all cases of high levels of clozapine. What is pathophysiology behind this? How to anticipate this silent danger in patient on clozapine turned positive patients?
Is that what is intoxication with clozapine? What is that?
Yeah, that there is possibility of intoxication of clozapine with clozapine.
Intoxication.
Meaning
So
possibly
basically, in acute COVID state is cytokine storm. When there is a lymphopenia and other thing, you should not use COVID. As Rajesh has told that only the long COVID, as soon as the acute symptoms subside, if there is a necessity with a proper evaluation, if there is a definite need, you can use with definite guidelines. Acute COVID, sorry, no.
Yeah. Okay, Dr. Srinivas Chakravarti says, it's a comment. Drooling of saliva is more debilitating symptom with clozapine, where present-day patients don't like to expose themselves as patient to outside world. It's high time to invent some same class of drug without salivary and with less cardiac and sedative side effects. Yes, sir. Thank you. We would love that utopian dream of having the perfect antipsychotic. Dr. Ramesh Babu again. Oh, that's the same question is repeated. Dr. Darpan has also asked the same question. Most of these are okay. Yeah, I think we have finished with the questions. We have a comment which has come, which is we discuss the brainstem involvement and neurotropic nature of SARS-CoV-2 virus. In more than 50% of post-COVID patients, we expect neurological complications of hyposmia, hypergeusia, headache, fatigue, insomnia, Guillain-Barré syndrome, impaired cognition, etc. Any comprehensive or updated plan by our Indian psychiatrists and neurologists to handle or prevent these brainstem-related neurocomplications has to be discussed detail in this webinar or a following webinar. Yes, sir. This is the comment we have received from, I don't know who, Dr. Ramesh Babu has sent this. So, right, any closing comments from Dr. Nagpal, Dr. E.Mohandas? Amita, I think we have finished all the questions.
My comment is basically because of the time frame, we cannot really go on discussing. I heard the comment on a brainstem involvement that itself, if I talk it, the mechanism, etc., it will take itself 30 to 45 minutes only the brainstem mechanism. I do have my slides, but anyway, in one of the sessions, if they want to have it, you can involve very faculty and do it. I can really help them in getting the literature. Thank you very much.
Okay. Dr. Nagpal, comments?
I would just like to state here that please start using Clozapine by 25 weeks. The patient is not showing response, at least before 2.8 years. That is my message to all of us, including myself. I would also like us to experiment with only using ANC as a monitoring machine instead of the WBC, TLC, DLC, and minimizing cost. I would also like to thank Alchem Laboratories for sponsoring this entire program today.
I'll do that. Yeah. Okay. So thank you, Dr. Mohandas, Dr. Nagpal, and all the participants who participated. And I think the best question we would like to consider the question by Dr. Colin Braganza, where what should be the approach for a middle-aged client, known case of TRS, maintaining 300 milligram of Clozapine for 10 years, being treated for diabetes who develops myocardial infarction. Would be prudent to continue Clozapine or taper and consider turning an alternative drug. So
recording
that is
stopped.
One of the questions which I felt was very nice and very practical, dealing with day-to-day situation for us in clinical practice. So I think that is the question by Dr. Colin Braganza that can be considered for the best question. And of course, the comment from Dr. Ramesh Babu is worth consideration only if he promises to write to the IPS, IAPP, and NIMHANS and AIMS HODs and ask them to prepare guidelines and the Indian Association of Neurology and get them activated to prepare guidelines for long-term management of neuropsychiatric complications of COVID. So thank you very much. At this juncture, I must thank all the participants for having taken time out from their busy practices, as well as to Alchem Laboratories, which is, with its unrestricted educational grant, helped us put together this unique topics together, which I'm sure are different in context of what has been happening around with all the webinars. And of course, they have a product, Alkepin, which is Clozapine. But primarily, the grant was so that we could talk about the neuropsychiatric complications of COVID and the long-term COVID, because it looks like we are going to have COVID for the long haul, and we are going to start
recording in progress.
We are going to start dealing with many more complications of COVID in psychiatric clinics. So thank you very much, the whole team which helped organize it, the Alchem team. Anybody from Alchem, Iltiza or anybody, would you like to say a few words? Mr. Iltiza?
Sir, it is okay. Thank you very much for this.
Okay. So is that all, Iltiza? Okay. So thank you very much, Amita, showing us. We hope to see you again on Tuesday on 8 June, 8 p.m. to 9:30 p.m. We'll send you the topic as soon as possible. You can watch all our webinars that have been held till now on Banai India YouTube, and also you can send us the feedback, and we can send you the webinar archives. Yeah. Thank you very much, and very nice of you to attend. Hope you benefited. Good night, and keep safe, keep your masks on, and get vaccinated. Thank you.